lot of biomarkers we can gather today, and we're still learning about these, and we've had them for a long time. I think what makes these digital ones different is they're usually very low cost. People have the phones already. A lot of times there's nothing special you have to do. It's your phone is collecting these passively, so we call it passive data. There's no engagement perhaps you have to do. So the potential of all this data being there is exciting. But again, we have to remember, just because we have access to it, we have to prove it's valuable. We have to deal with this in an ethical way. It certainly can be invasive if it's used in the wrong way. It could be coercive if used in the wrong way as well.
What you're talking about is a sea change, right? I mean, for those of us in psychiatry, I mean, I'm thinking about myself having entered med school 23 years ago. That experience of meeting with a patient and interviewing her or him is really unchanged. Of course, we use meds differently. We have more medications. We have different types of short evidence-based therapies. But the actual process of interviewing has a positive data. What you're saying is it could be very different in the near future.
It could be very different in the near future. And in some ways, you're right. We've become more sophisticated, more nuanced. But to take a historical example, in Germany in the late 1890s, Emil Kraepelin, who coined the term, who coined eventually what was schizophrenia, the reason that he kind of began to separate out what we now call bipolar from schizophrenia was he kept longitudinal note cards on his patients. Right. And he had these longitudinal note cards, and by looking at things longitudinally, he said, I'm noticing two trends. Patients may present similar, but these patients that are bipolar have one course, and schizophrenia have a different course. And from those longitudinal note cards, he almost again defined what is today bipolar and schizophrenia. Right. You wonder now if we have a new tool to quantify these mental illnesses. Will it help us kind of better subdivide illnesses, better become more specific in our terminology? Will we improve our nosology as a field? So I think that can only help everyone to have better, more accurate, more functionally based ways to understand these illnesses.
In some ways, what you're talking about is introducing data the way we have in physical health. God forbid you have trouble with your heart today and end up in our emergency department while visiting Toronto. You would have some blood work done, you'd have an EKG, they might refer you to a cardiologist, you might have some imaging done, maybe even a stress test. By the time you saw that cardiologist, there'd be a wealth of data available. The cardiologist would sit down with you, the cardiologist would still take a history, but there's data available, and right now in psychiatry there's a paucity of that.
Exactly, and I said you would still, I think sometimes people say, well, if we have all this data, we're not going to talk to patients, we're going to discount the patient experience. And I think the whole point is to say, that's not what we're doing with this. We're augmenting, we're adding to, we're understanding the context of how a person is presenting their experience. So it's not a kind of either or, it's what someone feels and says versus what the data says. It's together, it's a much richer picture that really helps us understand how people are experiencing mental illness and lets us kind of get the right treatments that meet their needs.
So maybe we could even diagnose earlier. So somebody's sleep pattern who has bipolar affective disorder suddenly changes. What might we be able to do on the treatment end?
We certainly know that people spend a lot of time on screens. Perhaps a topic for a different day is what is the impact of screen time on mental health? There's almost a new paper every week, and you've covered some of these that say good, bad. It's almost like smoking sometimes. Is it any screen time bad? Diet? But in terms of what we can do with these screens is we can really connect to people in new ways on demand. There's a lot of smartphone apps now offering different types of cognitive behavioral therapy, CBT. There's different smartphone apps offering almost every type of cognitive therapy. Someone has made a smartphone app that offers to kind of give you on-demand skills. Some can connect you to coaches, to therapists, to clinicians, to peers. You can quickly get support. Some of these apps are good for safety netting. If you're not feeling well, they can connect you to emergency services. Some can try to predict when you may be at risk of relapse and kind of give you early warning signs. Some can be as simple as just medication reminders. So I think we have a whole spectrum from an alarm that pops up and says, hey, it's time to take a medication or exercise, to things trying to do machine learning on your data to kind of find personal predictors of when you may be at risk.
What about severe mental illness? What are things that digital psychiatry might help us in terms of understanding illness experience?
Research that we're doing in our group is saying, can we help predict relapse in early course schizophrenia by getting permission to look at people's smartphone data in real time? And we're learning, I said, we're still conducting the study, and I said, so we don't have any final results, but we're learning that signals that you and I would never thought were important could be important. For example, your phone knows when it's charged, right? The power state, the battery, it goes up. And most of us, at least I charge my phone at night when I go to sleep, and I uncharge in the morning and the battery goes down. You can imagine that perhaps days that people forget to charge their phone, they charge at different times. Could that be kind of a marker, a proxy for cognition? If you're not doing as well, if your cognition is beginning to decline, do you forget to charge your phone? Do you charge it differently? So could something as simple as charging your phone pattern give us an insight into when relapse could be imminent? I said, we don't know yet, we're doing research, but perhaps if I check back with you guys in 12 months, I can give you an update.
But it looks like that sort of unusual data set.
Yep.
Right. So I've never asked a patient in my office, have you had a change in your battery charging pattern recently?
It's new data, there's new things we'll learn. I'm sure there'll be unexpected things, and there'll be things that we think should pan out that won't.
I mean, this sounds great, but what are some of the problems we're having in these early days?
I think like anything in early days, you want to say extraordinary claims require extraordinary evidence. I think that's a quote by Carl Sagan. And if we're saying that we're going to have these wonderful new tools to help us diagnose, understand, or treat, you want to say, where is the extraordinary evidence? And I think we're seeing some very exciting pilot studies. We're seeing some very exciting feasibility studies. What we're not seeing are the studies that replicate, the studies that say it worked again in a different population with a slightly different type of patient, with a slightly different twist on it. We're not seeing the same thing work twice. And the whole potential of technology is it's scalable, right? If it works in this little pilot study, the reason we're excited is it could work on a population level.
You have written about 75 papers, 5 book chapters. You've presented nationally and internationally. What's the biggest surprise so far?
I think the biggest surprise is still that digital health surprises a lot of people. The fact that psychiatry, I would almost argue, is leading the way in digital health. The first, at least in the US, FDA-approved apps are in mental health and substance abuse. And I think audiences are still kind of saying, wait, our field is do this? Mental health is actually taking the lead in kind of this type of research. And I think perhaps now in 2019, we're beginning to see the potential in a broader way. But I think there's still a lot of catch-up that we have to do of educating the public, sometimes our fellow clinicians, about what we can do and how we can do it, and to make sure we do it ethically.
Quick Takes with CAMH Education is a production of the Center for Addiction and Mental Health. You can find links to the relevant content mentioned in the show, a video version of the episode, and accessible transcripts of all the episodes we produce online at porticonetwork.ca/podcasts. If you like what we're doing here, please subscribe. Until next time.